Now, once you've already diagnosed a person with suffering from bulimia nervosa, now you'll go about the treatment plan, or how do you basically manage these individuals is again very important. Obviously, as any psychiatric comorbidity, you will go about the psychotherapies first of all, depending upon the severity of the disease. If the person can be treated or can be counseled out of the situation, well and good. And if the psychotherapies are not enough for that individual, then we'll move on to the pharmacotherapies, which are usually conjugated with the psychotherapies for the management of that particular individual that we're dealing with. Then again, the comorbidities are again very important over here. The history taking is very important. How do we go about the comorbidities and the management of the comorbidities as well is again very important. If he's suffering from any psychiatric comorbidity, we'll go about in a way that the psychiatric comorbidities, if it is severe enough, we'll treat that first of all, and then we'll move on to the treatment of this eating disorder, which is the bulimia or the anorexia. So over here, we're just focusing on bulimia nervosa and how do we manage or how do we make a treatment plan for this condition, which is the bulimia nervosa. The psychotherapies, obviously, they consist of the CBTs, that is the cognitive behavioral therapy, depending upon the thought form, depending upon the thought content, the delusional state of that individual. We'll focus upon the thought content of that particular patient that we're dealing with. We'll get the complete history, of course. We'll get the history about the self-esteem, about the body imaging of that particular individual that we're talking about. And then we'll move on to changing that thought form or that thought content. The fear is going to be dealt with, the delusions are going to be dealt with, and the strong desires to lose weight are going to be dealt with accordingly. Then we'll move on to the pharmacotherapies. Now, there are a lot of drugs that are usually inculcated in treatment plans that are designed for the treatment of bulimia nervosa. So sometimes we conjugate these pharmacotherapies with the counseling sessions or with the CBTs to get a better outcome. Now, the outcome usually depends upon the fact that if the person is suffering from any comorbidities and what is the severity of the comorbidities is again very important. This is how the prognosis of the patient goes about. So it's very important to focus upon these factors because the outcome is going to depend upon the treatment plan, the management plan of that particular patient that we are dealing with. Now, regarding the management, the patient engagement and motivation is again very important over here. The eating disorders not otherwise are specified. That is, they are not quite specified whether, sometimes they are not specified whether it is an anorexia or whether it is a bulimia. Sometimes it's a confusional state, but still we have to manage these cases, even if it is a mixed disorder of the eating type. The BMI is usually more than 17.5 in patients suffering from bulimia nervosa. These psychological treatments, we basically deal with the behavior of that individual, the thoughts of that individual, and then the feelings of that individual. The behavior consists of the binging and the purging phenomena, and then the thought form usually consists of a low self-esteem, the delusional thoughts that he has gained weight, or he has gained some excessive weight and he has to lose that weight, the feelings that he has, the strong desires to lose that weight or to lose that the extreme consumption of food by vomiting, by enemas or laxatives. And this self-harm behavior is dealt with when we are dealing with the psychological treatments or when we are inculcating these psychotherapies for that individual. The core beliefs are dealt with, then thoughts about the future, thoughts about himself, and thoughts about others. So that is going to reveal the thought content of the individual. Questions are put forth to the individual to describe himself, to describe the people around him, and to describe how he sees himself in the future. What does he think about himself in the future? And all of these thoughts usually reveal a very pessimistic view while we are dealing with any case of bulimia nervosa. The cognitive behavioral therapy, abbreviated as CBT, is usually inculcated in the treatment plans. There are usually 15 to 20 sessions, and after that we usually get a desired outcome in that particular individual. The individuals are usually treated individually, or sometimes they're treated in groups. So treatment in groups is usually sometimes it has a better outcome than treating the patients individually, because people suffering from a same delusion, from a same feeling, can be treated in the particular way by the psychotherapist. So it depends upon the psychotherapist, how does he decide, or how does he go about his management plan. There can be the self-help approaches as well. The person is basically taught how to get him self-help. By how does the person can self-help himself and get himself out of that purging or out of that binging episodes. Books are available, and even the online help is available for these binging and the purging phenomena that the person suffers from while he's suffering from bulimia nervosa. There are a lot of self-help programs. So even if the people cannot go to the psychiatrist or cannot get the help from the clinicians, they can administer these self-help programs to get themselves out of that particular situation if they have the insight into their psychopathology. Now, the pharmacological treatments, usually the first line treatments are the antidepressants, obviously. Now, as you can see over here, the antidepressants are these one. Basically, it is the tricyclic antidepressants that we usually administer in these individuals. And as you can see them over here, they basically are bound at the NMJ junctions, that is the neuromuscular junctions. The noradrenaline reuptake transporters are inhibited by them. So that is basically the histamine receptors over here, they're acting over here. The histamine is basically shown, or it is symbolized in this way over here. And then we have the muscarinic acetylcholine receptors over here. Acetylcholine can act as a reuptake, or as basically it can act as a activating phenomena. So sometimes if we depress this acetylcholine, it can inhibit that binging phenomena that the person is suffering from. Fluoxetine is sometimes administered, and it can also reduce the binging phenomena in these individuals. The pharmacological treatments, usually we also observe the anticonvulsants if the person can go into seizures, and if he has the seizuring phenomena, we can administer the anticonvulsants. For example, diphenylhydantoin is one of the anti-seizure or one of the anticonvulsant drug that is administered in these individuals. Then there are the tricyclic antidepressants, the imipramine. The outcome and prognosis basically depends upon the comorbidities, how does they exist. 40%, it's basically a good outcome. If it is just a patient suffering from bulimia nervosa, we can get him help, we can get him those self-help programs observed in these individuals, and mostly it is quite a good outcome in these individuals suffering from bulimia nervosa individually. It can be 18% intermediate depending upon the severity of disease and depending upon the comorbidities that the person is suffering from. And then we have the 21% poor outcome in these individuals as well. The factors predicting the improved outcomes are the early age at diagnosis. So if it is diagnosed at an early age, the person can be helped quite in a very beneficial way, and the person can get out of the situation quite easily. If it is a brief interval before initiation of the treatment, it's again one of the factors that can improve the outcome. The good parent-childhood relationship. So the childhood history is again very important over here, and we can emphasize on the fact to get a detailed childhood history, because it is going to have an impact on the outcome of the treatment plans. The healthy social relationships are again very important over here. The criteria for hospitalization in eating disorders is the heart rate. For anorexia nervosa, it is the heart rate less than 50 beats per minute. The systolic blood pressure is more than 90 millimeters of mercury. The orthostatic changes in the pulse are more than 20 beats per minute, or the blood pressure is more than 10 millimeters of mercury. There are arrhythmias, or the temperature is less than 96 degrees Fahrenheit. The body weight is less than 75%, or ongoing weight loss if it is observed in people suffering from anorexia nervosa. The body fat is less than 10%, or there is refusal to eat, there is failure to respond to the outpatient treatment. So all of these is the criteria for hospitalization in anorexia nervosa. Moving on to the bulimia nervosa, The patient can suffer from syncope. Serum potassium is less than 3.2 nanomoles per liter. Serum chloride is less than 88 millimoles per liter. There are esophageal tears, cardiac arrhythmias, hypothermias, suicidal risks, intractable vomiting, hematemesis, failure to respond to the outpatient treatment. So basically, this is the criteria for the admission when we are treating a patient with bulimia nervosa. Now, this is basically a timeline for the discovery of the binge eating disorders. They were discovered somewhere around 1959, and then they were mentioned in the DSM in 1987. And after that, basically the binge eating disorder association was formed in 2008 just to treat the disorders. In 2013, the binge eating disorders were formally recognized in the DSM, and in 2015, the FDA approves the use of lisdexamfetamine diacetylamide. So it's basically one of the treatment modalities that has been inculcated for the treatment of the binge eating episodes in the bulimia nervosa. So this is basically how this eating disorder has been discovered, and the work has been done for the improvement on the outcomes of this bulimia nervosa. So basically in this section, we worked out how can we manage a case of bulimia nervosa and what treatment modalities are present for treating a case of bulimia nervosa. So that is the end of this section. Thank you for watching sqadia.com.